Hello, everyone, and thank you for joining our webinar today with Dr. James Phelps. Dr. Phelps is a psychiatrist, author, and nationally recognized expert in bipolar disorder who has specialized in bipolar spectrum variations for over 15 years. He currently serves as the bipolar section editor for Psychiatric Times. His internationally known no-profit website, psycheducation.org, focuses on complex bipolar variations. It has received over 1 million visitors to date. Dr. Phelps has authored more than 15 peer-reviewed articles and books on mental health and mood disorders. His book, A Spectrum Approach to Mood Disorders, is written for a professional audience, while his book, Bipolar, Not So Much, is targeted for patients and families. Dr. Phelps received his medical degree from Case Western Reserve University and completed his residency in psychiatry and a fellowship in medical education at the University of New Mexico. His current work focuses on primary care psychiatric consultation. Welcome, Dr. Phelps. It's a pleasure to have you with us.
Thank you very much, Melissa, and thank you to the International Bipolar Foundation for the invitation, this opportunity to talk with you all. I'm very pleased to have it, and I think it's quite a privilege. Let's get going. We'll see what happens. First of all, again, I think the IBF has been an exceptionally important program, and I think many of our listeners are members and previous donors, and further contributions are always welcome. If I manage to do something useful here today, teach something useful, if people want to say thank you, they could send a donation to IBF, the IBF organization. Well, so anytime you're listening to someone like me, you ought to wonder, who is this guy and why should I pay any attention to him? Thank you for that introduction, Melissa. Here's the rubber on the road stuff. I've been doing inpatient and outpatient psychiatric work for 25 years or so, and I had 15 years of working in an outpatient setting where progressively I ended up spending more time working with people with bipolar disorders, have ended up somewhat specializing in that. And as Melissa said, right now I focus on primary care because there's a lot of folks out there with depression that has bipolar disorder of some kind in it, and we're trying to help people find that in primary care and manage it there because we don't have enough psychiatrists to go around. In the process of all that, I wrote this website called psycheducation.org about mood swings that aren't manic. This doesn't make me any money, and so I'm not here to sell anything. So that's my website. If you find some of these ideas of interest and you want to pursue them further, you can go there and see much longer presentations about all these ideas, including all the references that I'd want to show you. And these are the books that came out of that website. As it says on the website, if you like what I do there, you could go buy one of these books and hand it to your psychotherapist. Other than that, I won't be mentioning them. So I have 3 things that I'd like to try to come across with you in the next 30 minutes. First is that a spectrum approach to mood disorders, not yes or no, do you have it or not, but rather, well, how bipolar are you? That kind of an approach is increasingly accepted amongst mood specialists around the world. In fact, it's so widely accepted, it's a bit of a puzzle as to why people are still using the old way of yes or no, you have it or you don't. So we'll focus on that issue first. And then we'll talk about how subtle hypomania, if there really is such a thing as subtle hypomania, which I will try to show you, if that's true, then it really changes the whole concept of bipolar disorder, because no longer then is it something that you either have or don't have. It's more like you can have some degree of it, and that means trying to figure out whether people have some degree of it is a big challenge and has all sorts of implications that I'll try to show you, including here are 3 specific implications that I'd like to look at with you. And this might look a little technical, but I'll show you in layman's terms what I think this means. The role of 2 particular medications, Lamotrigine and Lithium, and that's a different form of lithium that I call low-dose lithium, and something that's been getting a lot of attention lately called mixed states, and then finally what this means about antidepressants. So here we go. First, this spectrum approach idea. Well, so again, when you hear somebody like me talk, you should approach it with skepticism, as you've surely learned to do, and go, well, show me why, show me the evidence for this. Why should I buy this idea? This would be an evidence-based approach as opposed to the use of alternative facts, which seems to be prevalent these days. All right, so what is this spectrum thing? The idea is that instead of being purely unipolar, that would be plain old major depression, or, quote, bipolar, meaning like bipolar II or bipolar I, that there's this territory in between. And as I've shown here with the color bar, the idea is that it's an undividable spectrum. There's no clear cutoff between any of these entities. Even though we have names for them, we think of those names like green or blue or red, like colors on the electromagnetic spectrum. They're not things, they are just points on a continuum. So that's the spectrum idea. The DSM, our Diagnostic and Statistical Manual, is still set up around a dichotomy, a yes or no system. You either have bipolar or you have unipolar. So it might come as a surprise to you that in the most recent version of the DSM, which came out in 2013, the very chairman of the DSM, that's David Kupfer, the chairman himself has said in print, in fact it came out right at the same time as the DSM came out, the new DSM, he said that affective disorders should be thought of as a continuum. In other words, it's variable expressions of bipolarity, meaning how bipolar are you, representing dimensions of underlying processes. In other words, this dimensions thing is the jargon term in our literature for the spectrum view. The opposite of dimensions in this is categorical, a system of categories. That's the DSM. You either have it or you don't. Whereas here is the chairman of the DSM saying, no, it's dimensional. It's a continuum thing. In other words, he's saying it's a spectrum. The head of the National Institutes of Mental Health at that time, when the DSM-5 came out, was Tom Insel, and he said, we can't succeed if we use the DSM categories. He basically said, right as the DSM-5 came out, he said, we aren't going to use it. The National Institutes of Mental Health, our own research program for the United States, says we aren't going to use this new DSM because we think this system of categories is not adequate to guide our research approach. So the NIMH has basically abandoned the DSM categorical approach. Right around the same time, the NIMH chief of what was then called the Bipolar Spectrum Disorders Group, notice the term Bipolar Spectrum Disorders Group, the head of that group said, categories are arbitrary because they're imposed on these fully continuous, smooth distributions. In other words, just as the color bar shows, it's a continuum from purely unipolar, plain old major depression, to fully and clearly bipolar, a continuum. There are other people. How about the head of the largest research program in the United States, the STEP-BD, that was Gary Sachs. He has said the very same thing all the way back in 1994. And then lastly, partly for your amusement, I just like how this came out in the hands of Eduard Vieta, who is a bipolar specialist from Barcelona, Spain. He said, dichotomies are useful for education, communication, and simplification. Dichotomies like the DSM, yes or no, you either have it or you don't. Unfortunately, simplicity, like these dichotomies, is useful but untrue, whereas complexity is true but useless. If you make it too complex, you end up hamstrung. So the way I think about this is that our challenge as diagnosticians and challenges for patients and families when they're trying to figure out, well, how bipolar is Sally, is to recognize that that's a very complex question, and then to make it just simple enough that we know what to do, but not to oversimplify it into something like a yes or no answer. So this cartoon from the New Yorker has sort of, this is an emblem of what I've been doing for the last 15 years. So she looks at it, she says, it's good, but it doesn't say bipolar. That's kind of what I do on a daily basis, is try to help people understand, well, it might still be bipolar-like, even if it isn't, quote, bipolar. So in other words, we're talking about a mood spectrum. Sometimes people refer to this as the bipolar spectrum, very frequently, in fact, but really we should be talking about it as a mood spectrum because it is the continuum from one end to another. If you have questions or concerns about any of that, and again, if you were to go to my website, which won't make me any money, you could see all the references that I'm talking about, all the various people, mood specialists around the world that I think represent this view. It's extremely widespread view. It's really the norm from what I can see amongst the mood specialists. So if you have questions or thoughts about that, write them down because we'll be doing a question and answer session here in about 30 minutes, 20 minutes. Shifting gears then, let's look at this idea of subtle hypomania. The original title of this talk was a more nuanced view of hypomania because it's the subtle hypomania that is the middle territory. On the graph here, it would be this zone of green where people have depression all the way along this continuum, but they also have in here something that we would think of as like a subtle hypomania. So what does that mean? Well, this graph is one way to think about that. Again, we have a continuum, a spectrum of hypomanic or manic symptoms from none to fully present over here in the E bar. But again, these sections like A or B or C or D are just chopping up what is a continuum into pieces so that we can talk about it, trying to make it simple enough that we can communicate, but not forget the complexity of it all. So if we were to take the E section, what does hypomania or mania look like way over here on the right-hand side in E? That looks like this. These are the official DSM criteria, distractibility, insomnia, grandiosity, and so forth. But what does that actually look like? Here are descriptions that I've seen in patients over many years of what it's like in terms of distractibility. Basically, people can't function. Their mind is just all over the place. Or in terms of insomnia, they are just not sleeping at all or hardly at all, an hour or two at night. So these are the extremes, but the point of laying it out for you like this is to look at what happens to these symptoms when we see them over here at C, again arbitrarily just taking a middle point in this continuum. Let's look at those same symptoms there in the middle. Here we get, again, the same symptoms from the DSM, but now it's just, patients have told me this so many times, people who love to read say, when I'm in this phase, I can't read at all. It just won't go into my head. I just look at the same paragraph and I'm reading the same paragraph over and over again because my mind is going way too many places besides what I'm reading. Insomnia is a matter of waiting a long time to fall asleep and waking up a lot, but not completely going without sleep. Grandiosity changes to just confidence. So we really ought to be not looking for people to be grandiose. If you wait for that, you'll never see anybody as bipolar except if they have bipolar I, the full mania. Instead, it's a matter of confidence that people unusually, for them, experience this willingness to go out and do things socially. They can go to a party and actually think that people might want to talk to them, which is certainly not their usual. So big changes in confidence that are really dramatic, and the person is scratching their head going, how did that happen? Some days it's just like that. That's what we're looking for in this diagnosis. And so on through the rest of these manifestations of hypomania. They're just more subtle than they are over here at E. And again, because this is a continuum, you have people over here as well. So basically what you end up with is this shades of mania getting really dramatic over here on the right-hand side and being very subtle down here on the left-hand side. So the problem then is that if the diagnosis of bipolar disorder depends on being able to see this, to see a subtle hypomania, well, some diagnosticians are going to see it and some diagnosticians won't. So you end up with this problem that it depends on whose telescope are you using. If you're like Jack Sparrow, you can see hypomania like I do. But if you're waiting to see it through a conventional telescope, you may not really call it bipolar until it's way over here on the right-hand side. So unfortunately, patients who have hypomania like this can see different therapists, different diagnosticians, and be told by some, yes, you have bipolar disorder, and by others, no, you don't, and find themselves very confused. So this is the confusion that I deal with all the time, trying to explain what we've just gone through here, that no, bipolar disorder is not a yes or no. In the view of mood specialists around the world, it is a spectrum deal that you can have some degree of bipolarity. Well, now let's look at what are the implications from this. What happens if you take this spectrum view in terms of treatment? Because it's all well and good to have this theoretical discussion about where exactly is the boundary between plain depression and bipolar disorder, and that's this big debate. But it's a little easier to see what this really means when you look at its implications for treatment. So that's where we'll go now. So we're going to look at these three facets of applying this spectrum idea. First, let's look at the role of two particular medications, and I'll explain as I go why am I focusing on these two medicines? There are a lot of other medications that we use in bipolar disorder. I also ought to take this moment to point out that I'm interested in these medicines because they are among the least problematic in terms of long-term risk and daily side effects. When I'm working with patients, I'm sort of jumping the gun here because we ought to back up and go, wait a minute, what about non-medication approaches? Is there a way to treat, say, subtle bipolarity here in the middle of the spectrum without medications at all? We can treat plain old unipolar major depression with just psychotherapy. So is there a way to approach this with just psychotherapy? And that's a very active area of research actually at the University of Pittsburgh. There's a psychiatric researcher there and clinician named Holly Swartz who's studying using a bipolar specific psychotherapy to treat this without any medications at all. That treatment approach we can talk about more in the question and answer session. It focuses on a very regular pattern of sleep and careful management of light and darkness to facilitate that regular pattern of sleep. And then we may also have to consider medications, and there are two in particular that I want to look at. So let's do that. Lamotrigine, many of you may know, was originally an anti-seizure medication that has been around now for 20 years at least, and we have adopted it into psychiatry for the treatment of bipolar II in particular. There are properties of Lamotrigine that make it really ideal for this. And the bracket that I've put here is designed to imply that for bipolar I, over here on the right-hand side, Lamotrigine is not so specific. That's because Lamotrigine is not generally regarded as having solid anti-manic properties. It can be an antidepressant. It has clear antidepressant effects in many people, and it is a mood stabilizer. It can stop cycling, but it is not reliably anti-manic, so that someone with bipolar I couldn't get away with just Lamotrigine by itself. That wouldn't give them the protection against a subsequent manic episode. Thus the bracket limit here. But this open question of, well, how far down in this direction does Lamotrigine's benefit go? It clearly has antidepressant and anticycling benefit for these people. Can it help these people? So far, the research suggests that these people are unlikely to get a good response to Lamotrigine. It's somewhat bipolar specific, although there hasn't been a lot of work there, and a few studies say, yes, there's been value. Most of the data, to my eye, suggest that Lamotrigine doesn't really belong over here, but how far down in this direction it goes is an open question. The other reason to focus on Lamotrigine is because it is, I think, perhaps our only psychiatric medication that has no significant long-term risks that have ever been described. So here's a medication that it appears that you can take safely for decades, and we cannot say that about really any of our other medications. For example, it doesn't cause weight gain, which is the many of you know from, and many of you from personal experience, that psychiatric medications of many types can cause weight gain, and Lamotrigine is an exception there. It is generally regarded as weight neutral. It doesn't cause weight loss, but doesn't typically cause weight gain either. Now, there are a few people out there who have gained weight on Lamotrigine. It's true, and they're ready to pipe up there in the audience. But by and large, the data say people don't routinely gain weight on Lamotrigine, certainly not by comparison to almost all of our other medications. So because of its long-term safety, it has a short-term risk that almost everyone knows about. That's Stevens-Johnson syndrome, the rash, this risk of developing an allergic reaction that can be extremely severe, which is something on the order of 1 in 1,000. Some references would say 1 in 2,000. A few say 1 in 3,000. Notice that's 2 or 3 times less common than the usual 1 in 1,000 rate that's cited. And so we're going from 1 in 1,000, like relatively rare, to 1 in 2 or 3,000. We're talking rare. But a significant risk. Once you get up to speed on Lamotrigine and the dose is no longer changing, that risk of that Stevens-Johnson syndrome rash, the 1 in 1,000 or 1 in 2,000 risk, that risk goes almost all the way back to 0. Not quite to 0. Some people develop Stevens-Johnson syndrome even if they're not taking Lamotrigine, so there is no 0 rate, but it's almost 0. And that means that it's a transient 6 to 8 week window of risk of this very bad allergic reaction at a 1 in 1,000 rate. So that's Lamotrigine. From a safety point of view, it is far, far better than most of our other alternatives. And second benefit, most people who are taking it have no side effects at all. A few people have some nausea or headache when they're going up. If they slow down, back up a little bit, you can work around that. And the other side effect that once in a while makes people stop taking this is hair loss. It is true that Lamotrigine can make your hair start falling out, and some of us, I'm pointing at the top of my head, don't care about that, but others care very much. So that means that, yes, there will be a few people who have to stop Lamotrigine because of side effects, but not many. And most people feel nothing at all, so much so that we actually have to tell people, now you'll feel like you're not getting any benefit from it because it doesn't feel like it's doing anything. The whole point is to prevent mood cycling, so be careful. It'll seem as though it's doing nothing. So obviously I'm a big Lamotrigine fan for all these reasons, and partly what I'm doing here is using my pulpit here for the moment to speak out against the general treatment guidelines for bipolar disorder that emphasize medications with very significant risks. So quetiapine, trade name Seroquel, or lorazepam, trade name Latuda, which can be singled out for its unbelievable expense compared to other options, or the quetiapine because of its potential for sedation and weight gain, or olanzapine, trade name Zyprexa, again for tremendous potential for weight gain. Those are the generally recommended medications for bipolar, including bipolar depression, to my astonishment, because as you can gather by comparison, I think Lamotrigine is a much, it's an unsung hero. So I'm trying to sing it up here. So that's Lamotrigine. And then there's low-dose lithium. Low-dose lithium is almost a different medication than full-dose lithium. Full-dose lithium carries risk to kidney. It can cause thyroid problems, as I think most of y'all are aware. And it can have potential side effects, particularly tremor, that can be very limiting in terms of people's ability to tolerate taking it for months to years at a time. But low-dose lithium is much less likely to hurt kidneys, and that risk takes a decade to develop for nearly everyone. So there's plenty of time to figure out that's going on, and that risk is lower the lower the dose is. Low doses don't cause tremor. Low doses don't cause much in the way of side effects for many, many people, and that's why I think it's appealing. And as the green line shows here, lithium has value all the way across the mood spectrum. But in this context today, it particularly has value for these folks who aren't bipolar, but they aren't really unipolar either. Lithium is one of the specific medications that I use a lot, been trying to teach the primary folks to use a lot, because at low doses its risks are low and its benefits can be substantial. This is lithium at, quote, sub-threshold or sub-therapeutic blood levels, tiny doses like 150, 300, 450, 600 milligrams, as opposed to 900 or 1200, the common doses in full dose lithium. So the implications then of a spectrum view is that it opens up the possibility of using these medications for people who don't have bipolar disorder, but they have more than unipolar disorders. Two more things to cover here, and then we'll take some questions. Mixed states are now recognized as common and associated with danger and anxiety. That's what I want to look at next. So, brief history lesson. Back in the 1950s and 60s, the DSM manual was the DSM-3, and this is where the term bipolar disorder came from. It's like the North and the South Pole, and there was no such thing as a mixed state at all. There used to be, before the DSM, that was recognized, but the DSM-3 had sort of disappeared there for a while. And then with the DSM-4, it returned, but it was only this upper right-hand corner of the graph. The rest of the territory of this graph was by definition not a mixed state. But you see here the idea that mania and depression are not polar opposites. They are actually separate dimensions, and that you can have both of them at the same time. In fact, as soon as the DSM came out with this, in the very next year, Susan McElroy and colleagues at the University of Cincinnati said, no, 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 the whole territory of the graph is a mixed state. And this is the way I've been looking at mixed states ever since. It just makes a lot of sense to me. It's a spectrum view of mixed states. It means you can be somewhat mixed as opposed to entirely and thoroughly mixed. Well, the DSM-5 has come along and said, okay, the DSM-5 has enlarged the idea of mixed states to be the upper 2/3 of the graph. There are some pieces of it that are still formally excluded, but I'm still working based on Susan McElroy's approach, and this is a really widely accepted way of thinking about mixed states. Well, what's important about mixed states? A couple of things. First of all, recognize that what we're talking about here is subtle hypomania. In other words, you can be depressed, you can be really depressed, but if you're a little mixed, you also have not mania, but hypomania, maybe even a subtle hypomania. And what does that look like? In my view, the most common symptoms of subtle hypomania in this context with depression are agitated, too much energy. It's like being all revved up and ready to go someplace, and your body is definitely ready to do that, but there's nothing going on. Second, irritability can be really pronounced during these phases. This has been called dysphoric hypomania or a dysphoric mania. And irritability is often a very big piece of that. I'll have a disclaimer for this in a minute. In my experience, people's ability to concentrate, again, for example, ability to sit down and read a book, is one of the things that goes away because of this over-energization in this phase. And sleep changes. People sleep less. Mostly they experience this as, I wish I could sleep, not the, quote, decreased need for sleep, which is the formal diagnostic criteria in the DSM. They wish they could sleep, and they're asking their providers for medications to help them sleep. So it turns out that these four aspects of subtle hypomania are officially not allowed in the DSM view, but I think they're very widely accepted by mood specialists. So from my view, that debate about, do these count? Can we use these as indicators of mixed state? From my view, that debate is mostly an academic one. This is reality. So Alan Swan at the University of Texas and colleagues from the International Society for Bipolar Disorders published a review about mixed states in one of our premier journals. And here are their conclusions. First, that mixed states are very common. And then most importantly, anxiety is a mixed state symptom. anxiety, which we usually think of as like panic disorder or generalized anxiety disorder or even post-traumatic stress disorder, the anxiety that could get diagnosed as that can be a manifestation of a mixed state. In other words, there's people out there who do not have bipolarity, they just have anxiety, and we could call that generalized anxiety disorder. And it's not bipolar, and that's fine, and it can respond to psychotherapy, and that's great, and you don't have to talk about bipolar disorder at all, unless people get the standard therapy and they're not getting better. And then we should follow the old maxim that we learn in medical school: when your treatment isn't working, question your diagnosis. So we should be going, well, maybe this what looks like generalized anxiety disorder, could this possibly be anxiety that's associated with a bipolar mixed state? So to me, what the fact that the ISBD has declared anxiety to be a symptom of bipolar disorder in mixed states opens up the possibility that when people are anxious and having, particularly if they're having phases of bad anxiety, that we should be thinking about bipolar disorder as a possible explanation for that anxiety. Not all of it is, much of it is not, but some of it, some anxious depressions are bipolar. And the irony then is that these mixed states are dangerous. They're associated with an increased risk of thinking about suicide and making actual suicide attempts. So they're dangerous, they're common, and anxiety is one of their common presentations. And unfortunately, mixed states, according to the ISBD, can be induced by antidepressants, which is really ironic because for what's the standard treatment for generalized anxiety disorder that is not responding to psychotherapy, for example? The standard treatment is an antidepressant. So the very medications that people use to treat anxiety disorders can cause anxiety by causing a mixed state. It's a very messy territory. It's a very big problem in terms of accurate diagnosis leading to effective treatments. I spend a lot of time nowadays, particularly in primary care, trying to look at people with anxious depressions and figure out, well, could this be bipolar to some degree, in which case that antidepressant that you're taking maybe is not such a good idea. Now, mind you, those in our audience today here in our webinar, if you're taking an antidepressant and you're doing well, do not stop your antidepressant. If you're taking an antidepressant now and you have a diagnosis of bipolar disorder and things are not going really well, do not stop your antidepressant. You need to be talking to your providers and say, well, is there any chance that this antidepressant is part of my problem? I am experiencing what I think might be mixed states, and maybe is the antidepressant possibly related to that? That's a discussion that you need to have with your providers, because stopping antidepressants is an extremely disruptive thing to do. It has to be handled extremely carefully, and you need a backup plan, like, well, what am I going to do if I'm getting worse? Sometimes that's going back up on the antidepressant, but in my hands, often it means going on to other anti-manic, anti-mixed strategies. So bottom line, don't stop your antidepressant on your own. But it is worth wondering if you're having mixed states and anxiety, whether the antidepressant might be contributing. So those are my cautions then about antidepressants. They can cause mixed states. They can cause some degree of mixity, if you will, and they're widely recognized amongst mood specialists to have the capacity to promote mood cycling. So, so we have to be careful about antidepressants. And the good news is that we have alternatives to antidepressants that have antidepressant effects. That would be Lamotrigine, low-dose lithium, and I didn't talk too much about quetiapine, trade name Seroquel, because it too has clear antidepressant effects. That's why I think of it in this context. It's an alternative to antidepressants for people with bipolarity, but it's also capable of causing tremendous weight gain, has a potential long-term risk of tardive dyskinesia, which these other medications do not. So it's kind of a last consideration for me, not a first consideration as it appears in many of the treatment guidelines. All right, so if you have learned something and you want to learn more, you can go to my website and learn a lot more, or to one of the books that are linked from my website. And again, I appreciate the opportunity to share these views with you and look forward to your questions and comments in our question and answer section now. Melissa, can I turn it back to you?
Yes, thank you, Dr. Phelps. That was very interesting. We are going to open up the discussion to the Q&A portion of the webinar. I will begin with the first question. Dr. Phelps, the symptoms of moderate or category C describe a normal productive person. Does this level of hypomania require medication?
Well, thank you for listening, and thank you for that's a very good question. It takes us, well, it's a rubber on the road question, isn't it? So again, the question then is, in someone right there in the middle of the spectrum, those symptoms, they aren't really symptoms. They're just like the experience of hypomania, where people feel energized and more gregarious, and they have more ideas and more things to say to people. That's not abnormal. That's just something that most all of us, I hope you all have had the experience of that from time to time. When it comes and goes, when it comes and then it disappears, and then there it is again for no clear reason, and then it goes away again for no clear reason. It's cycling. It's not abnormal, but it's abnormally present and absent. So that the cycling nature of it is what makes it a symptom that tells us that in someone who has depression at other times, that their depression is more than unipolar. If a person was to have that come and go experience of mild hypomania and didn't have any problems with depression, then for sure we would say we wouldn't invoke bipolar disorder at all. This is just part of the normal human experience. Some people are like moody, right? They're, they get their good days and their bad days. There's a bipolar diagnosis called cyclothymia for an extreme portion of that, but again, that means there's phases of depression in there. So it's the depression that drives us into thinking about bipolarity. In other words, if you're not having episodes of depression, we don't much care, but if you are you also having these cyclic experiences of mild, subtle hypomania? Because it may change the way we approach your treatment. Some of those folks do well on antidepressants, but for people who get an antidepressant like that and have a bad experience, or who try a bunch of antidepressants, then we should be thinking about Lamotrigine and low-dose lithium, in my view. Again, thinking about the possibility that this is a manifestation of bipolarity. So again, thank you for your question. Like, well, isn't that part of normal human experience? You're absolutely right. It definitely is.
Excellent. Thank you for that. I guess we could have started with this question, but could you please define unipolar?
Oh, good. Yes. And I'm sorry for jumping right past that. Defining unipolar, it's what I would think of as a pure or a plain depression. There's none of this bipolar stuff about it. So it's defined by the absence of any of the bipolar markers. First of all, it's defined by the absence of anything that looks like hypomania. And secondly, it's defined by the absence of other markers of bipolarity that aren't in the DSM. And I didn't really talk about this today, but there are other things that suggest bipolarity that aren't symptoms, and so they aren't in the DSM. For example, people with a first-degree relative who clearly has bipolar disorder, if they themselves have depression, and yet they have a bipolar relative, their depression is not purely unipolar because they have this marker of bipolarity, their family history of bipolar disorder. And it turns out statistically that means that people who have a family member who clearly has bipolar disorder, when they themselves become depressed, it is more likely that they will later get a diagnosis of bipolar disorder, and it is more likely that they will end up doing well on a mood stabilizer and less likely that they'll do well on an antidepressant. So again, statistically, it just shifts the probabilities somewhat. It doesn't make it bipolar, it just makes it not quite purely unipolar. And there are 9 or 10 other such markers besides family history. Early age of onset of depressions, for example, or a postpartum depression, or ever being psychotic, or having highly episodic depressions. All of these are things that make it not, in my view, purely unipolar, just plain old major depression. I hope that addresses your question, and thank you. That was a useful clarification.
Thank you, Dr. Phelps. That was very clear. Next question. What does category B look like on the A through E bipolar spectrum? For example, like a list of qualities for slightly bipolar.
Got it. For my colleague who's standing here and serving as my audience so that I know whether I'm making any sense or not, the question was, what does category B look like on that ramp of hypomania? Frankly, I'd written out some examples in my books, and I'd go back and consult them quickly, but it's simple. Basically, you just take all of those same properties and dial it down a little bit so that it's just barely there, but so it's not absent, but it's not obvious. So for example, distractibility. People just become a little spacier. They might forget where they put things. Now, of course, all of us do that from time to time, but if this, again, comes in cycles, like, man, I go through these phases where I'm just sort of not all there. My mind is like 6 places instead of 1. And then, oh, you know, a couple days later, I'm back to my usual self. How about insomnia? Phases of sleeping less well, just more awakening, more difficulty falling asleep, more tendency to wake up early. That's the least common. It's just subtle, but if it comes in waves and then goes away for no clear reason, then we start to wonder about cyclicity. And that confidence thing, same story, just subtle increases in confidence. Now you can imagine, when I start describing all that stuff, that's not bipolar disorder. Everybody goes through that. That's true. And if you don't have any problems with depression, then we certainly don't need to start waving our hands about bipolar disorder. But if you have depressions, and particularly if you have depressions that come and go, and you also have this subtle stuff, then I'm interested. And I'm particularly interested if you've already tried 3 or 4 antidepressants and 2 good psychotherapists, and you're still having difficulty with this stuff, then, well, you don't meet criteria for bipolar II, or even some of these subtle, like bipolar not otherwise specified, the middle of the spectrum. But you might have enough bipolarity that maybe you should think about trying Lamotrigine instead. It just kind of gives me permission to think about Lamotrigine when I can elicit in someone's history these subtle versions of hypomania. And then you could go, well, Phelps, you got your ears cocked so far forward, you could hear this stuff in nearly anybody's history. And I'm aware of that risk, so I try very hard when I'm conducting an interview not to lead the witness. I try to sit back and see if I can create a form in which these descriptions emerge spontaneously, and then I have more confidence that they're legitimate markers of cycling. So that's the B category. It's just take C and dial it down a little bit. Melissa?
Thank you for that. Next question. What is your feeling about patients using Adderall to help with focus, especially during hypomania?
Good question. Question is, what about people using Adderall to help with focus, especially during like hypomania? Well, you can sort of imagine the knee-jerk response is going to be, how about if we fix that problem a different way? How about if we try to prevent it rather than medicate it when it shows up? In other words, if focus is a problem during hypomania, well, what about just preventing the cycling into hypomania? Now, I've treated lots of patients, so I can just sort of imagine what's going through your mind when you hear that. It's like, dude, you don't get it. Hypomanias don't bother me except for this distractibility, and couldn't I just use some Adderall then? But most people under those circumstances are also having phases of depression. It'd be very unusual to be cycling into hypomania and not have usually parallel experiences of depression, usually coming right after the hypomania, sometimes preceding it, but usually right after. So again, then part of this knee-jerk response is, you see, it's those depressions that we could also fix if we go after the cycling. So let's go after the cycling. Yes, you will lose those phases of hypomania that you may feel like are your most productive, creative, exciting times, But in my experience, most people who get good solid mood stability are very willing to give that up in favor of not having episodes of depression. So that was the knee-jerk soapbox response. But what about Adderall, to go back to your question? Again, because it's an indirect solution, it's just not very appealing. And because Adderall has all sorts of other issues around it, it's not where I generally like to go. Ultimately, we don't have enough psychiatrists, so we need to be handing everybody back to their primary care providers once their medication regimen is stable. And if we hand you back to primary care and you're on Adderall, people are going to be wondering, well, what's this stuff for? It just raises all sorts of questions and fuss. So I try to avoid it just on that level because it's going to create difficulties down the road. And of course, as you know, it can be diverted and sold to other people. And so every time people prescribe it, they're anxious. And making your prescribers anxious is just not a good state of affairs. So there's those just kind of basic reasons to avoid the Adderall. Beyond that, though, I couldn't argue with it too much. People have used Modafinil, for example, which is a medicine used in the treatment of narcolepsy just to keep you awake, and it's been used as a stimulant, used to treat ADHD, and somehow it just doesn't have the stigma that Adderall has. And so, well, what if we were talking about Modafinil here instead of Adderall? It would be a little easier, frankly, to swallow, so to speak. So again, most of the problem around Adderall, beyond the fact that it's an indirect solution, is that it's got stigma and creates its own problems. Otherwise, it's hard to argue against because it doesn't generally cause trouble. And a last thought on this, well, wait a minute, can't stimulants induce manic symptoms? Surprisingly, most of the data so far, we don't have a lot, it would be great to have much more, but most of the data so far don't suggest that when people are on a good solid mood stabilizer regimen, that adding a stimulant will mess things up. There are some people where it will indeed mess things up. But when people are on a good solid mood stabilizer regimen, and that includes the non-medication approaches as well as medicines, adding a stimulant doesn't generally seem to increase cycling. It frightens me to do it because when you try to make a poor little lab animal manic, one of the ways to do it is to drop amphetamine on its brain. But okay, so that's enough of the old soapbox stuff. As you can gather, it's not a simple, straightforward answer unless you just go, hey, how about we stop the cycling first? Thank you for your question.
Thank you. That was a very interesting answer. We have a couple more questions. The next question is, with regard to Lamotrigine and Stevens-Johnson syndrome, is there a risk of it occurring when coming off of Lamotrigine or only when initiating it?
Lamotrigine and Stevens-Johnson only when going on or also when coming off? My understanding of literature is that it's only when going on. Basically, it's one's immune system being tricked by this foreign molecule into somehow thinking there's an in-house problem, that something needs to be attacked, and the immune system gets revved up and goes on the attack against one's own, usually skin, but sometimes there are other manifestations of this huge and sudden immune response going off. Rarely it can inflame the lining of the brain called the meninges. So there's it's like a meningitis without an infection. So aseptic meningitis, quote unquote, is the way of having another reaction to Lamotrigine. Very rare. So again, it's the immune system getting revved up by this foreigner showing up. So the foreigner going away wouldn't precipitate a problem. I'm going to guess that the person who asked this question, there's some personal experiences you've had where something happened while the Lamotrigine was going away. So we'd have to wonder about your experience, but in general, it's the going on, not the coming off. That's the problem. And that's why we go up slowly on the dose, is we introduce the foreigner slowly in order that your immune system gets used to it. And I will take this opportunity to point out one more thing, and that is that once you're on Lamotrigine, if you miss more than 3 doses in a row, you really have to get back on it that 4th day. If you don't, then your body will have lost its standard impression that this foreigner is present and not a problem. If you then reintroduce lamotrigine at your previous dose, then you can have the Stevens-Johnson reaction. So you can't miss doses on lamotrigine more than 3. If you do, you should call your provider and say, well, what do I do now? And most times he will say, well, we should start all over again with the titration. That's the cautious approach. Thanks for the question.
Got it. Thank you. Next question, is ECT a legitimate alternative therapy for hypomania / major depressive disorder?
So is ECT a legitimate alternative for hypomania / major depression? That kind of depends on which coast of the United States you're standing on. But let me back up a step. So the answer is definitely yes, because ECT is a remarkably effective treatment for depression. Now, and I'll come back around to this coastal thing in the United States in a minute. It's true that ECT, like all known antidepressants that I can think of that are formally regarded as antidepressants, ECT can precipitate manic symptoms. So it's not uncommon that people can go through a hypomania during the first couple of sessions of ECT, and then, but ECT also treats mania. So the usual approach is to, if there's been any induction of manic symptoms, you just proceed with the ECT, like, Monday, Wednesday, Friday, another session, until the whole thing is treated. So having bipolar disorder doesn't mean you can't do ECT. There is some potential for precipitation of symptoms during ECT, but you just continue it, and that's the way you handle that. So the reason I joked about which coast are you on is because here in Oregon, where I am, there are only a very few places in the entire state where you can even get ECT, and so we don't tend to start thinking of it until way, way, way down the road because it's so hard to get to. That's not an efficacy thing, it's a sort of ease of use thing. It's really arduous here in Oregon and many places on the West Coast and more rural Western United States. It's really difficult to get it.
Got it. Thank you. Next question. What should you do if you have a diagnosis of unipolar depression, but you believe you occasionally experience subtle hypomania like you described?
Question is, what if you have a diagnosis of unipolar depression, but you might occasionally experience some of this subtle hypomania stuff? Well, first of all, if things are going well, don't change anything. Or you can sort of be curious and maybe kind of start lining up your learning so that if things down the road weren't going so well, you'd be prepared because you'd thought it through. But getting a really good outcome in our business can be challenging sometimes, so it's really important that I not get anybody revved up here today to change something when things are going well. All right, so if they're not going well, people with unipolar depression tend to get another antidepressant. They might get lucky and get a really good psychotherapist and maybe even a second good psychotherapist. And if after all that, multiple antidepressant trials and multiple good psychotherapists, if after that things are still not going well, then I think it's pretty obvious you should start wondering about this bipolarity business as a potential explanation for why those treatments haven't worked. So you can sort of think of it as the farther down the spectrum you are toward plain old unipolar, the more you ought to try the standard treatments for major depression. Multiple antidepressant trials, multiple psychotherapy trials. The farther you are over toward the bipolar side of that spectrum, the fewer of those trials you should go through before you think about switching strategies. So that by the time you get over here to the middle of the spectrum, you'd be going, well, maybe I'll do one antidepressant, and if that doesn't go well, then I'll do lamotrigine. Or maybe a second antidepressant, And maybe now we're kind of shifting over to the antidepressant that's least likely to exacerbate bipolar disorders. Most people think that's bupropion, trade name Wellbutrin. So maybe that would be the next antidepressant that I try, and then if that doesn't go well, then I'm going to try Lamotrigine or low-dose lithium. I'm partly just riffing on your question here. I think the answer is fairly clear. If things are good, don't change it. If they're not, think about what I've talked about here today and wonder about maybe a mood stabilizer. Melissa, when you have just one more question, let me know, because I want to talk about what do you do with your antidepressant when you're thinking about adding a mood stabilizer? And for our questioner here with Unipolar, that would be relevant. Do you have one more question, Melissa?
Yes, we have one last question.
And then I'll jump in again with mine. Yeah, good.
Yeah. Okay, the question is, would you please contrast bipolarity with other types of periodic revving up, such as the emotional lability of the autism spectrum?
Yeah, important, thank you. Contrast this hypomania business, cyclic hypomania, with other causes of emotionally revving up, like, say, autism spectrum. And another that we might consider there would be so-called borderline personality disorder, a very unfortunate term in which psychiatrists, who are not exactly the most normal people in the world, turn around and label other people as having a personality disorder. It's not very good PR. So I prefer to think of that as borderlinity. There's this property of highly emotionally reactive, let's call it that, which is a feature of this borderlinity business. And then lastly, PTSD is the very, very common diagnosis because trauma histories are very, very common, and that can be periodic, and people can be highly emotional in phases where somehow something's triggering some physiologic or cognitive recall. So compare the hypomania cyclicity versus these other ways, including autism spectrum, of having emotional reactivity. Well, you can probably guess. The answer is, oh, it's hard, it's messy, it's really difficult to distinguish these things. A few of them have markers that distinguish them. For example, PTSD is supposed to have a trauma history. The problem is, all sorts of people have trauma histories. Not all of them have PTSD. In fact, in people with mood disorders, trauma histories are at least 50% common, at least in our population. In autism spectrum, mood reactivity and intense emotional responses to things is kind of part of the deal. So when is that bipolar? In my view, there's no clear way to answer that unless you have a bunch of other bipolar markers. If you have somebody in the family who's got a clear diagnosis of bipolar disorder, if mom had severe postpartum depression, if some other relative has clearly cyclic mood problems, not autism stuff, then I think as we would say, the index of suspicion, our curiosity and our concern about the possibility of bipolarity ought to go up. And the good news here is that all that's supposed to do is make it more possible to think about bipolar as a potential explanation, which opens up the possibility of using bipolar treatments as potential approaches. And if we're using lamotrigine and low-dose lithium, we're using relatively low-risk strategies. So it's not like we're going into the whole world of the atypical antipsychotics where the risks are really high in order to try out this idea. Thank you for that question. Melissa, how much time have I got left?
We should probably wrap it up pretty quickly here, but if you want to touch on your last topic, go for it.
Good, thank you. Brief shtick. Most people, when they're not doing well and they want to try adding a mood stabilizer, are going to be on an antidepressant. What do you do with the antidepressant? The brief version, in my view, is you add the mood stabilizer and you hope for at least a degree of improvement. And if you see it, but things are still not good, rather than adding yet more mood stabilizer, another option is to simply taper off your antidepressant. But when you do that, and you would not do that on your own, when you do that, you do it by the smallest decrements that you can engineer. In other words, if you're on 40 milligrams of fluoxetine, you go down to 35, and there's a way to do that. If you're on venlafaxine, you go down by 37.5 because you're stuck with that step down. The smallest steps that you can create over about a 4-month period of time, according to one authority from Harvard, Gary Sachs, is the way to taper that antidepressant. So really slow and really small steps if you're going to try that, and that's what you're going to discuss with your provider after you've added that mood stabilizer. So I just want to stick that in there because that's what I spend most of my time doing nowadays, is adding mood stabilizers and tapering off antidepressants. And the reason I'm still doing it is because I've been getting good results from doing it, and it's lowering risk, not adding it when you're taking medicines out, not adding them. Melissa, thank you for that opportunity to get my little plug in there for that idea. And thank you for this opportunity to talk today with your audience.
Of course. Thank you so much, Dr. Phelps, for sharing your expertise with us today. Thank you, everyone, and we hope you will join us at our next webinar. Take care. Bye-bye.
Thanks. Bye-bye.